And thank you to Melissa, Timon, and everybody here, BRCCH, for inviting me to speak at this seminar. I will be talking about, now we've heard about the lab, what happens in the lab. We have moved to modeling made easy. That's what Melissa has just done. And now we are moving out to the field to see what happens to the field, in the field when all of this is done. What happens in the field and what are some of the things we should be looking at and what are some of the things we should be thinking about. I think I'll move here. Okay, so I will start with an introduction. I will bring up some lessons from the qualitative evaluation. I will talk about looking forward. What should we be looking at? And then give some key messages and then end the, okay. So by way of introduction, the global technical strategy, which we are all working with now, includes ensuring universal access to malaria prevention as one of its 3 pillars. And so within the first pillar, beyond treatment, it talks about prevention. And we have several efficacious tools in the toolbox now, some for vector control, some for chemo prevention, and more recently, we have the first malaria vaccine, which is the RTS AS01 vaccine. Now, the pillar is what I'm talking about now. You can see in the first pillar, ensure universal access to malaria prevention. And we are talking about prevention now. So you see the different tools that we have, of course, excluding the case management part. All of these are preventive tools that we have and are working reasonably well. But when you look at everything holistically, you see that we have had 20 years of remarkable progress. We have been able to reduce the case rate. We have been able to reduce mortality, and malaria spending has gone up. Good, so that was very good. And then in the latter 5 years, we began to have a problem. But if you look at where we started from in 1900, you look at the map, everything red is where malaria transmission is going on. And here is how we have managed together to shrink the map. And some places are blue now, and the red is shrinking. So we've done a good job. But then we have seen that this progress has begun to stall. So progress has begun to stall, and COVID-19 has not helped at all. It has contributed to confusion in the whole issue and added to what we were experiencing. So you see everything going down. We should have been going down the green lines you are seeing, but we are traveling on the blue lines you are seeing. So since that period, we are not doing so well. So we are off track with cases, and this is from the, I'll quote a lot from the World Malaria Report 2021. We are, with cases, we are off track by 40%. With mortality, we are off track. And countries in my region, the African region, accounted for over 95% of the cases. So we have a real problem there. If you look at LLI, and when you look at the access and use, you see it's doing a nosedive. You see this is coverage with IRS also doing a nosedive. Then IPTP, which is intermittent preventive treatment for malaria among pregnant women, also heading down south. And then besides all of this, there are some threats that are going on. We have some endemic countries, in fact, the bulk of them which have provided data having detected resistance to at least one insecticide that we are using, and which we use in the nets and we use for IRS and many things. And so we have a problem there, and pyrethroids are in danger, and several classes of insecticides are in danger. So we do need new tools, and that's what Simon is busily working on. We need new tools. We do need new tools, but there's a greater need also to strengthen the implementation of the existing tools, because these new tools are going to come into a context or a milieu that the other tools are working in. And if we don't sort out whatever problems there are in that context, those very good tools, efficacious tools, when they get into the health system, they get into the real world, they'll begin to lose traction and will not do what we were expecting them to do. So since we are in Basel, and this is where the missionaries came from to my country with Christianity, I will quote something from the Bible. There's a scripture in the Bible in Song of Solomon. It says, "Catch for us the little foxes that ruin the vineyard." So I'm talking about the little foxes. They may not be seen as big things, but they are there, and they are in the vineyard, and they are ruining the vineyard. And if we do not deal with these little foxes, the newer tools and the strategies will face the same issues, and they will also join in ruining the vineyard. So the ITSS AS01 vaccine is the most recent intervention that has been introduced for malaria prevention. Others are in the pipeline. We have heard about the R21, which is very close to coming out to join the ITSS, and others are coming along. So the pilot implementation of this vaccine in Ghana, in Malawi, and in Kenya was done. And we looked at what was going on in Ghana. And as this vaccine was rolled out, we saw very good things, but we also saw challenges related to the caregivers themselves, the communities as a whole, and the health system also. And these give an insight into some of the implementation challenges that the earlier preventive tools have faced and continue to face. And we need to pay attention to these challenges, which are like the softer parts of things, as we strive to maximize the impact of the existing tools and introduce the new ones. So I'll go on directly to that evaluation. So this was carried out in Ghana, as I said, and WHO has since recommended that this be used for among children in moderate to high transmission settings. And these are the three first children who got this dose in Ghana, in Malawi, and in Kenya. These are the three children that were given the very first doses. So for the focus of the evaluation we carried on, and we'll be focusing particularly on the first one, what are the dynamics of the implementation? And how does this impact household utilization strategies? But I'll be focusing more on the first one than the second. So it was mainly a longitudinal qualitative approach over 36 months of people living in the community, staying with them, documenting what was going on, looking at what was going on in the health system. And for some of the places, I think Martha went to one of the places. For some of the places, we had to wake up at 4 a.m. if we wanted to visit the people living there to see how work was going, travel 4 hours, get onto a ferry, and drive another 2 hours to get to that community, which is in a very remote part. And this was where the evaluation was taking place. So this was happening in 3 regions in Ghana. And we spoke to caregivers and community members, including leaders of the community and private health providers and management teams, to be able to get a sense of what was happening. So it was mainly qualitative, it was mainly sitting and then ethnographic and picking what was going on. And the interviews were transcribed. We used many tools, which I won't go into. So generally, the uptake of the vaccine was very good overall. However, some implementation challenges were noted at the outset and also along the way, which had the potential to reduce impact or derail the whole process. I'll talk about a few of these. Fortunately, with this type of study we were doing, the agreement was that we should feed back as we went along to the implementers, so that if there's anything they can course correct. And so that was what was happening. So largely, some of the things that could be corrected and addressed were addressed. So we start with the implementation challenges from the caregiver side. The arrival and announcement of this vaccine was greeted with rumors and social media misinformation. So some people took it upon themselves to do videos, put them on social media in the local language and send them down to people in Ghana for circulation. And by the time the vaccine arrived, these rumors and misinformation were all over the place, and everybody in the remotest village had been told by their people in the city, watch out for this vaccine. If you don't know, and people whose husbands were in Accra would call their wives, do not take my child for that vaccination. So that was a problem. That was how the vaccine was greeted on arrival. But this was quickly counteracted by the minister and by many other things. And a lot of communication went on, and quickly that managed to die down to a large extent, not completely. One other thing the vaccine was also facing, it's being faced by all the other interventions, is that there's some kind of normalization of malaria in the places where it's endemic. So people, you hear people say, as for malaria, we live with it. It doesn't kill us. We are here with it. We suffer from it. We walk around with it. We take the drugs, and then we get back to work. What's the big deal? So that is an issue. That normalization is an issue. And the perception of risk from this disease is low. And that is a challenge we must look at, because if that does not change, people will not be so bothered about taking up interventions to protect themselves. It's not a big deal. And I think we are seeing the same thing with COVID. If I may say so, in the beginning, we would all have been in masks, everybody was, but with time, everybody's like, okay, so now we are immune. I mean, we are not going to die from COVID, so we are fine. And that's how people are in Ghana. And then when you look at, they have perceptions of the preventive strategies also, not with this vaccine, but with something like a treated net. You know, the way the net is shaped, rectangular. For some of the people, it's like they've been put in a coffin. You won't catch them dead inside the net because you are putting them in a coffin. The color also mattered. Some people are particular about what color of net they will sleep in, because if it's white, it has its connotation. So there were various things, and these are going on in the minds of the caregivers and the people who are benefiting from this. And then there's beliefs and attitudes. We'll read some quotes for you to understand about what causes malaria infection. We did some work several years ago, I would say over 20 years ago, in Dodowa, where we were working. And at that time, the perceptions people had, my impression was that that had changed totally in this place where I moved to. But actually, it hadn't changed at all. And for some people, malaria is still caused by eating oily food. And for some, it's by working hard in the sun for a long time, you can actually get malaria from that. And if that is so, such a person is not going to do anything about any mosquito around, because you just avoid oily food and avoid working in the sun, and he or she should be fine. So this was this is the milieu in which we are. And for some, the information they received was, they had all sorts of information. And then there's this thing also in many African settings where to go to the health facility or to receive services in some communities, they need permission from certain significant others, i.e. oftentimes it's the husband, and they must get this permission before they do. And therefore, they were not going to take the child. But one woman told us, my husband called me from Accra and told me not to take my daughter for the vaccine. Well, I listened, but I looked at it and I think my daughter is going to benefit from it. So I took my daughter for the vaccine. And when he comes, he will be no wiser because it's an injection. So he won't know that I've taken it. And I've done it because I want to protect my child. So this is one of the things that you see there. Then from the community side, they also had their own rumors and things, but community engagement was an issue where some of the management committees were not interacted with at all. So when we spoke to them, they said, well, all we know is what we've heard on the radio and on social media. Nobody has spoken to us about what is going on. So we are watching, but we know that this vaccine will cause sterilization among our people here and reduce our population. So we are not going to allow anybody to take the vaccine. So this was also going on. Then implementation challenges in the health system. This is where the real problem is. The health workers themselves had their own perceptions. Remember, they come from the community. They also are community members. So there were some health workers that we knew who were in our study refused to allow their children to take vaccines, but they were delivering the vaccines to other people. They were community health workers, so they were responsible for giving out the vaccine, but they would not allow their children to take the malaria vaccines. And we followed this very closely. In some cases, they were not sure about what was going on. This was linked to the kind of training that was carried out. And then the quality of service delivery was an issue from the provider side. In the health system, leadership issues was a problem. Leadership is a big issue, and the leader of the health team is a very key person, and that was a problem. And the training mode that was done became a problem for this vaccine. And I dare say many other such tools, because the training is often done in a cascade manner. So a few people like you, a few people are taken to the district health directorate, they are trained, and they have to go back and train the other people in their health facilities. And as the training goes down, there's a watering of the message and all of that. And then people don't understand what was said and what was not said. And there's all this confusion. So we will see that as we go along in there. And then supply chain issues, you will see a quote on that. Logistics like fridges, books for documentation, awareness and demand creation activities, funding of movement to where the vaccine has to go was an issue in some places, and poor supervision, as well as the irregularity and unpredictability of service. So let's see some of the things that people were saying. So one of the staff said, inadequate funds. The little that has been sent from the national or regional, that's what we use. But it's inadequate because during implementation, all those kind of activities, we need to go to the islands, but we can't go. We have the boat, we need fuel, we cannot go. So here is one typical one. The most critical one has to do with the cold chain system. 5 facilities don't have a standard refrigerator, and anytime there's prolonged light out, it's a challenge. Then when you look at vaccine stock out, you see from the first quote that there was stock out at some point. So they rescheduled the mothers to go and come back because their vaccines had expired. Then books for documentation. There's supposed to be a new tally book that captures RTS, but unfortunately we don't have it yet. So we have to rely on the old one and rule lines with pens to make space for RTS. That's a challenge because you may forget. So here is where the issues begin. So this is coming from some health workers. And then the training things I talked about. The 2 days of training is a problem. Just imagine going for a workshop and they have compressed the training session so much that what you would have used 3 days to learn, you used 2 days for that. It didn't work for them. And then they saw something on the WhatsApp platform, they should have had it, they didn't have it. So all of these issues are going on. Now look at what community members are also saying. That one of them was bold to tell us the mosquitoes are around, and I put my net up in the wet season, the dry season, I take it off. And I've also explained this to other people, and they are also doing same. So he has gone ahead to recruit other people into this belief system, and it's going on. This is a preventive intervention. Others, what they said, you see that they understood whatever it is. So looking forward, what should we be looking at? What should we be thinking about? We need to bend the curve. And if we need to bend the curve and stop this trajectory we are following, with all of this going on and knowing that now we are moving towards tailored interventions, where we look at what is in the context and apply the intervention, what should we be looking at? So we have the software of it, we have the hardware, and we have the financing. We have underpinning that leadership and accountability. So we are targeting, we are looking at subnational tailoring, and this requires a paradigm shift in the mindset of people. And we need to get people to now begin to think that we are moving towards getting rid of malaria. How do we go about it? We need to look at context-specific implementation, pay attention to the context. Implementation research needs to support what we are doing. And if we do that, we'll be able to use the resources wisely because we have the answers we need for that particular setting we have. And community engagement at this point in time, when we are talking about subnational tailoring, I cannot overemphasize. We should remember that this is not the only intervention that is happening there. There are several interventions, and these new ones must fit into that system. And it's important that the community is on board from the very beginning. When we come to the hardware, the health system must link up with other sectors. Agriculture is doing dams and things in the milieu where the nets are being put. And if we do nothing about it, people will sleep in their nets, fine. They get outside, they sit outside their house, they are bitten by mosquitoes. We need to relate to other sectors, housing, roads, to health facilities, water, sanitation. It's an important thing going forward. And using the tools in a smarter way, as we have talked about. The development and deployment of new tools, these are the hardware, they must go on. But we must take cognizance of the threats that we have talked about. R&D to support this must go on, as I said. But we must also have a paradigm shift in this area. It should be top priority for the government where this disease is worrying their people, where the burden is high. This is where this should be the priority. For instance, the African Union, and there are entrepreneurs and rich people in the high burden countries. They should also be incentivized to get more involved in these things and also help to develop solutions for prevention in our backyard. And high burden countries should lead the advocacy efforts to keep malaria high on the agenda. The solutions we need must drive the agenda, and the R&D networks must be strong, north-south and south-south as well. And sometimes south-south, we don't talk to each other at all. All of us do a lot of north-south, and we must begin to look at that. And another thing where, and I'm taking quite a bit of this from Rethinking Malaria also, where there was a big effort, and Marcel was part of that as well, to see what needs to be done going forward. And increased domestic funding is important. I served on the Global Fund for a while, and many times countries which have the burden would not fulfill their counterpart funding. They won't. They will just not be able to get that. And that was a challenge because you are getting money and bring this so that it's put together for your own people becomes a big issue. And we should now begin to recast funding for malaria as an investment. Actually, it's been seen that when money that is put into managing this disease increases the GDP per capita, we should start presenting this to politicians with this in mind. And if we present it that way, that's the language they will understand. We have to get out of the malaria box and speak the language of politicians and purse holders to get them to help with this. So that's the finance part. And leadership, accountability, and commitment, ownership. And commitment is very important for us to move along. Regional and sub-regional alliances are a thing of the future, because in some of the countries which have regressed, what is happening is that they have eliminated malaria. On their border is a country that is high burden. People are crossing across, and mosquitoes don't need any visa to move across the border. So the mosquitoes move across. You can stop the people, but the mosquitoes will cross and they move in and out of the border. And that has become a thing we should be looking at. And this, I think, is a picture of commitment. It's one where this is from one of the remote areas when we were doing the study. These are 3 health providers, one carrying, there's no transport. This is the motorbike they have. The treated nets they have to deliver are in front of the person who's driving. It's a bit dangerous, but that's what they have to do. One is carrying the sharps bin, the other is carrying the vaccines in the vaccine carrier. And they are going to a very remote community to deliver the malaria vaccine. This was taken at that time. And I say this is commitment. So there's a call to advance equity also. We must pay attention to subnational variations, some of which I have described, and the social determinants of the malaria burden. And we should try not to leave anyone behind in contributing to the fight. So we are not leaving people behind in benefiting from the fight, but people should not be left behind and not contribute to the fight as well. So that's why I talked about the entrepreneurs, and the communities are ready to work with us if we do want to work with them to make sure that interventions we put in place achieve their maximum impact once they understand what good it is going to do. So soldiers on the field don't leave their wounded behind, and we should not be leaving anyone behind as well. So finally, the key messages I would give is that malaria can and should be eliminated. We're optimizing the use of our existing efficacious tools for prevention requires a collective effort with community buy-in. And we do need the new tools and strategies that are being developed now. But unless and until we try to deal and address the implementation challenges, some of which I've spoken about, and carefully address them, the new tools will only come and join the other tools and may not achieve the best they can achieve. And I want to acknowledge all the people who I've been working with from, we worked together at Kwame Nkrumah University, Cape Coast together. The 3 universities worked together on this project, the regional health directorates and the Rethinking Malaria initiative that we work on, the global malaria program. A lot of the graphs were taken from the Lancet Commission on Eradication, Professor Binka, who also gave me some slides. And these are the funders that supported us in this. Thank you for your attention.